So your gallbladder is a liquid soap dispenser that helps you digest grease. And Americans tend to eat a lot of grease, and even if you're not, the gallbladder still needs to function for your digestion to go smoothly. For the most part, your gallbladder should function without you being aware of it doing anything at all. There are a number of things that can go wrong with the gallbladder. The most common is gallstones. Your gallbladder lives under the rib cage over here on the right-hand side. It's fixed to the liver. Your liver all day long makes bile, whether you're eating or not. The bile is a byproduct of the breakdown of your blood system. And the bile collects in your gallbladder between meals. And when you eat food, there's a chemical reaction that allows the gallbladder to squeeze. It empties out. And the bile goes through this bile tube down here, mixes in with your pancreas juices, which are your digestive enzymes. And digestion actually begins below your stomach. Your stomach is for storing the food. And the digestion begins when the bile mixes with the pancreatic enzymes, and then it begins its trek through the intestinal tract. All liquid soap dispensers in your house will develop soap scum. And that's basically what gallstones are. The gallbladder empties, but it doesn't empty entirely, and the bile that stays in there can get dehydrated, and when it does, those concretions roll around like soft Play-Doh and eventually make stones. Some people have really large stones, other people have really small stones. Once the stones form, 80% of people live their lives, never have an attack, and the stones are not a problem. So having gallstones by itself doesn't mean you got a problem. However, because they're there, occasionally they're going to plug the tube up, leaving out of the gallbladder. And when that gets impacted there, it generates a tremendous amount of pressure in the gallbladder, and that pressure causes pain and frequently nausea. And the pain is usually in the upper belly on the right-hand side. That pain can be very intense, or it can be just a back-achy sort of thing. It'll be as intense as labor pains for people or kidney stone pains, but not always that intense. Once the stone is there, it can move back into the gallbladder, in which case you suddenly are okay. It's like somebody hit you with a voodoo doll pin. Wow, you're fine, but you were in horrible pain 2 minutes ago. Or the stone can stay there and make your gallbladder inflamed, and it can be achy and tender for a number of days. On occasion, there'll be an impaction of the stone and germs are back behind there, in which case the gallbladder gets infected, forms an abscess, there'll be a fever over 101, severe pain that won't go away, and that becomes an emergency. So the gallbladder with stones can become an emergency. There are other gallbladder conditions where the gallbladder functions too high, runs too hot, it expels so much so fast it generates pressure and makes you miserable. That's called a hyperdynamic gallbladder. There are functions where the gallbladder does not empty out well and is really sluggish. It's called biliary dyskinesia. And when that happens, it also causes abdominal pain. If you don't have stones though, and you have a hyperdynamic gallbladder, or you have biliary dyskinesia, it's usually a misery factor, and you're usually not going to develop an emergency as though you have gallstones. We diagnose gallstones with an ultrasound test, and it's wrong 15% of the time, telling you you don't have stones when you do. Nothing in medicine is perfect. So it is possible that patients who think they are not at risk for surgery as an emergency actually are. So if you're having gallbladder pains, the recommendation is get your gallbladder out. If you have stones, the chances of an emergency are 50-50 in the first year, year and a half of an emergency arising. So emergency symptoms with gallbladders would be severe pain that's not going away, usually over 6 hours worth, fever over 101, or if you're turning yellow. And patients with gallstones can have small stones or big stones, and the small stones can pass through the gallbladder and get impacted down here rather than there, in which case the bile in your liver can't flow, it backs up, and your eyes turn yellow, your skin turns yellow. And if you have fever and pain, and you're yellow, your chances of dying in the next 24 hours are quite high. That's called cholangitis. So gallstones can precipitate problems beyond the gallbladder itself. And the other problem that it can precipitate is irritation of the pancreas gland. The pancreas tube comes in down here like we were talking about, and if a stone impacts there, it constipates your pancreas. And that has all your digestive enzymes. And if those digestive enzymes can't flow where they're supposed to, and they back up into your pancreas gland, you'll have pancreatitis, where your body actually digests itself. And the longest I've personally taken care of a patient who's been in the hospital with pancreatitis is 13 consecutive months. Most people are in the hospital with pancreatitis 2 or 3 days, but it can be severe, and it can be life-ending, and it can turn you into a severe diabetic. So if you have gallstones and you're having gallbladder pains, the recommendation is to get your gallbladder out. Now, gallbladder surgery is typically done as an outpatient procedure. It's usually done laparoscopically and frequently done in an outpatient setting unless your health status otherwise would dictate that you need to be in the hospital. Most operations are done laparoscopically with small incisions, and the operative time is usually about an hour. At Meridian Surgery Center, people are generally at Meridian Surgery Center about 4 hours. An hour to get an IV in and meet the anesthesiologist, an hour in surgery, and a couple hours of recovery time, waking up, getting dressed, and getting instructions, etc. When the gallbladder is out, your digestive tract no longer has a liquid soap dispenser. Therefore, you should be on a low-fat diet, and I recommend a low-fat diet for a couple of months after the surgery to minimize problems with cramps, bloating, gas, diarrhea that mimic irritable bowel. Patients who already have irritable bowel, where they're alternating between diarrhea and constipation all the time, once they get their gallbladder out, those are the patients that are at risk of long-term problems with their intestinal tract. It usually shifts them over onto the diarrhea side and can remain there permanently. So about 4% of people after they have their gallbladders out will have some problem with diarrhea, and they're typically people with irritable bowel. There's a medication for that slows it down. It's called cholestyramine. It lowers your cholesterol, helps with the diarrhea, doesn't even get absorbed into the body. It stays in the intestinal tract and solves the problem. My mother has been on that for 30 years since her gallbladder was out, and she thinks it's great because it solved her irritable bowel problem, but she has to take it every day. So those are one of the downsides of having your gallbladder out. Gallbladder surgery has been done for over 150 years. And back in the Great Depression era, when the gallbladders had been out for some time, they noticed that people who'd had their gallbladders out 20 years ago were getting colon cancers and pancreas cancers and lung cancers. And there was a big concern that doing something abnormal, like taking a gallbladder out, was causing all of these problems later on in life. Luckily, during the Great Depression, they had a lot of out-of-work PhDs, and they did a really big epidemiologic study looking at people who'd had their gallbladders out a long time ago and determining whether there were any long-term consequences. And their conclusion was, as is still the case now, that when you have your gallbladder out, really, there are no long-term consequences. There are short-term consequences in terms of risk of surgery, but unless you have irritable bowel up front, the chances of you having long-term symptoms because your gallbladder out are pretty low. But up front, we recommend a low-fat diet. While the bile tube adjusts, it's initially going to be relatively small. After a couple of months of storing soap in it, it stretches out. It goes from a little tube to a relatively large tube and stores your bile. And for most people, their function from their gallbladder is normal after that. So removing the gallbladder is about removing the source of stones. It's removing the source of pain, and it is replaced internally by an adjustment within the bile system. So most people have no long-term consequences of having their gallbladder out. Now, gallbladder surgery, like any surgery, has inherent risks with it. One of the things that can happen the risk of this is 1 in 1,000, is injury to the main bile duct system. We notice that this connects up here, and when we take the gallbladder out, we disconnect down low, take the gallbladder out, and leave the bile tube alone. However, there are 40 different anatomical variations in this area, and frequently it's inflamed, frequently it's contracted with scarring, and if there's any injury to the bile duct, you'll leak bile out. And anybody who's had their gallbladder out who is feeling worse and worse and worse about a week after surgery, it can be severe pain, it can be just bloating and feeling like you got to have a bowel movement, but the bowel movement doesn't solve it, but you're getting worse and worse and worse. About a week after gallbladder surgery, they need to have a bile scan to evaluate that. And my recommendation to anybody who's had gallbladder surgery is call the surgeon. I need to know about that. The emergency room docs don't know what to order. The family docs don't know what to order. They get the wrong test. You can get a CAT scan and completely miss this thing. But the sooner it's diagnosed, the sooner it can be dealt with, and it does require a second operation. The risk of that's about 1 in 1,000. That's happened to 4 of my patients in the last 25 years. So it does happen to real people. And it's something that just need to be in contact and making sure that your surgeon is in the loop. Now, the other thing that can happen, that happens quite rarely, is injury to the other intestines. And this has only happened to 1 of my patients in 25 years. But when we're operating in the belly, there's always inherent risk that the other guts can get injured. That's typically, and in my case, this was the case, somebody who's had major surgeries before, a lot of big scars, and internally things are tethered down in places where they're not normally at. That would manifest itself within days with severe pain. And again, the surgeon needs to know about that. Now, when you take the gallbladder out, you're taking out what looks like it's the problem. Say it's got gallstones, or it's hyperdynamic or low function. But there's a lot of other guts in there, and other things can be wrong. And it's circumstantial evidence when you're having pain in the right side and gallstones that the gallbladder is the problem. And when you take the gallbladder out, 90% of the time you'll be solving that pain problem, which on the flip side means 10% of the time you're not solving the problem, and other things can be wrong. In which case we begin looking for other causes. If you have biliary dyskinesia, the chances of you getting better with your gallbladder out are about 85%. So not quite as high, but pretty close to patients who have gallstones. So if they're continuing to have pains, again, getting involved with the surgeon, other tests need to be done. There are patients who have a blockage point in their bile tube down here that causes ongoing pain or potentially stones there. And for that reason, during the operation, I will take an x-ray of the bile tubes to look specifically for gallstones to make sure that no gallstones have been left in the bile tube, because they can cause pancreatitis later on. And that is the other potential side effect of gallbladder surgery, is leaving stones in the bile tube that can cause pancreatitis or cholangitis at a later date. So it's my practice to take the x-ray on a regular basis as a process of getting the gallbladder out to be sure that the bile tube is clean and free of stones. If there are stones in the bile tube, they're down below what we can deal with the gallbladder, and it's usually behind the pancreas gland. So those stones need to be dealt with a second procedure done by the gastroenterologist, usually about 2 to 3 weeks after surgery. In the hospital, it's a procedure called an ERCP, and they can successfully go down through the throat, around the intestines, and then suck those stones out from this little tube junction down below there. And the goal, if you have stones at the end of your gallbladder episode, is to have those stones all gone, both in the gallbladder and the bile tube, and then you can leave that part of your life behind you. Okay, now I've got a really unpopular subject, and that is complications after surgery. All surgeries have potential complications. Some surgeries have different complications from others, but there are some that need to be watched out with every operation. One of those are things that people naturally are afraid of, and that's bleeding. For most operations, the risk of bleeding is relatively low, amounts to bruising, and rarely results in transfusion. If you have religious objections to blood products, be sure and let your surgeon know about that. But rarely do we need to proceed on with any bleeding, transfusion sort of issues in general surgery and the stuff that I'm generally doing. But there are a few things that can increase your risk of bleeding that you need to be aware of. Aspirin increases bleeding, it increases bruising substantially, and unless your doctor feels like you need to be on aspirin despite the fact that you're having surgery, most patients will be taken off of aspirin. Likewise, ibuprofen, Aleve, any of the non-steroidal anti-inflammatories also have the same effect on clotting. So we'll generally have people off of those medications for a few days before surgery. External bleeding is very obvious. If you've got a spot of blood this big on your dressing, it's probably going to stop on its own. If your dressing, however, is soaked and looks like it's continuing, you need to notify your surgeon right away. Frequently, that will get better just by applying pressure. But if it doesn't, it will need to be addressed during a close time frame there. Don't be polite to your surgeon. I like that if you are, but don't wait till morning if you've been bleeding all night. That can be a real problem. And let the surgeon know if you're soaking your dressings. The other way that you know you have bleeding is something you might not think of up front. For most operations, we want you up and around the house the night of surgery. And walking is good. It prevents blood clots. It keeps you mobile. But it also gives us an early warning sign. If you're attempting to walk the night of surgery and you're pale and you're passing out, that's either a heart problem or that's internal bleeding. That's an automatic trip to the emergency room, and nobody should talk you into going to bed because you're dehydrated, you just need to rest. If you're pale and passing out, or just passing out period, when you try and walk, that's internal bleeding and needs to be evaluated that night. Call 911, call me on the way. Infections are also a risk with surgery, and anytime the intestines are cut across, there's a higher risk of infection. Wound infections are not common at Meridian Surgery Center. The risk is about 1%. If your wound is red and angry, if it's draining pussy stuff, if you're having a fever over 101, those infections symptoms are generally going to occur in the first week to 3 weeks after surgery. It's a nuisance. It might scare you, but it's probably not an emergency that requires an emergency room visit. And if you go to the emergency room, you're going to be there 10 hours. Calling the surgeon, texting a picture is the better way to do it, way faster, way cheaper, and will save you a lot of trouble. I had a patient 2 years ago who was pacing in the emergency room with this problem. He'd been there 4.5 hours. He was getting really mad. Other people were going ahead of him. He wasn't getting any attention. And he just went, I'm supposed to be calling Dr. Wright. What am I doing here? And we had it all figured out for him within 15 minutes. So be aware, the emergency room isn't generally the place for that kind of a problem. Let's get it taken care of. Anesthesia-wise, your operation generally involves anesthesia. Local anesthetic has very minimal risks, but if you're allergic to lidocaine or bupivacaine in the dental office, we need to know that because that's what we're generally using, something related to that. General anesthetic and sedation procedures have risk of anesthesia as well. We're generally evaluating that in the clinic as we go along with the surgery evaluation, and patients with high risk are generally done in the hospital setting. Patients with intermediate risks and low risks are in this outpatient setting. But that's part of why we're doing blood tests and EKGs in evaluation before surgery. And sometimes you'll be set up for an outpatient surgery, and those tests will either cancel the surgery and require a cardiac evaluation, or change the setting of the surgery, or tell us something else needs to be done before the operation is done. But we deal with, in the outpatient setting, minimizing the anesthetic risk and getting you through the operation as smooth as possible. you'll be speaking with the anesthesia provider specifically about your situation the day of surgery before you go in for surgery. If you have sleep apnea at baseline, we do ask you to bring in your CPAP mask because that can be helpful in the recovery phase when you're not breathing so well and when you're not as awake, sort of like it helps you at night. Medications that we give after surgery can have reactions too, particularly if you've never seen them before. If you've had problems with certain pain pills before, we need to know that up front so that we don't get you into the same trouble that you had before. But generally, narcotic pain medications are constipating. And the number one distress call I get is usually 4 days after surgery. Somebody hasn't thought about how their bowels are working. They've had their surgery, they're doing okay, but now they can't poop. And it can be the most miserable part of your operation if you're bloated after an abdominal surgery and you can't poop and you have to push it out, and nobody wants to give you an enema. So you need to be proactive on that. So the night of surgery, drink plenty of liquids. When you're starting to eat, don't jump into meat and potatoes. Instead, fruit and vegetables. You want lots of fiber in your diet that will help you with your bowels in that immediate postoperative period. And if you're a constipated person in the first place, clean out before surgery, take laxatives, and keep your bowels working. You would rather have the trots in 2 days than bricks in 4. But certainly keep an eye on it. If you normally have really good bowels, you don't even have to think about it, be thinking about it. If you haven't had a bowel movement in 2 days, you need to take a laxative and get things going and make sure that you don't get bound up. That's the best way to have a smooth operation after the operation. So when it comes to complications, nobody can tell you all the possible complications. There are a number of things that can go wrong. Your informed consent forms will give you a lot of answers there. But generally speaking, the more experienced your surgeon is, the less complications you're going to have because they've seen things before, and that experience helps them keep their patients safe. So at Meridian Surgery Center, you'll see a lot of experienced surgeons and providers at your bedside, guiding you through your operation to minimize your potential for infection.